Hey, what's going on, sports rehab experts? This is Greg Schaible on behalf of sportsrehabexpert.com, and today we are coming at you with a new training that we're doing for the website. And the purpose of this training is to really kind of tease into the 12 big stereotypes or the 12 big myths of rehab and strength and conditioning. Now, I think it's extremely important to be going over these 12 stereotypes because as a profession as a whole, from physical therapists, athletic trainers, strength and conditioning professionals, chiropractors, we tend to be very opinionated and live on the extreme ends of those opinions. And I think Mark Twain says it best here. It ain't what you don't know that gets you into trouble. It's what you know for sure that just ain't so. And I think that's something that happens a lot within all of our professions as we get to learning, as we take the continuing education courses. We try to find information that we currently are unaware of, or we try to find new information. It's something that we currently don't know. That's what we're always trying to strive for, and that's how we're trying to always get better. But we don't spend enough time asking ourselves what we currently think is true, and is that still true with what we now know? This field is still a very young field, and it's an ever-changing field, and a lot of new information always comes to light. So we have to always be going back to what we thought we knew and make sure that we still know that material, or if something has changed, that we update our thought process, because it's what we thought we knew for sure that just isn't so, that gets us into a lot of trouble if we never self-check our beliefs and don't keep an open mind to constantly evolving, constantly adapting. So keep that in mind. It's not necessarily always about the new material that you need to search out for. It's about what you think you currently know that actually just isn't so. So today what we're going to be doing is challenging 12 stereotypes that I find in the rehabilitation and in the strength and conditioning profession that might not actually be as true as what you believe them to be. And that's why this training is called the 3 sides to every coin, is because when you look at a coin, there actually is 3 sides. A lot of people view coins as having 2 sides, but there's also this middle edge of the coin too. So there's this edge that we have that separates the heads and the tails portion of a coin. And it's knowing both ends of the spectrum that allows you to make a more informed decision. If you're only viewing one end of the spectrum, you only have one lens to look at the argument from. So in order to have a better understanding of the current argument or the current situation or the current problem at hand, we have to view both sides of the equation. We have to view both sides of the spectrum to be able to sit perfectly on the edge for a moment and realize which side we may or may not want to bias ourselves towards. It doesn't necessarily mean you have to sit perfectly on edge the whole time. Again, it's a spectrum, and it's an ever-evolving spectrum based upon the information that you currently have, but it's perfectly fine for you to operate just like a pendulum, which allows you to sway back and forth depending on the circumstances or experiences that you have as a clinician, which makes you a more adaptable clinician or strength coach depending on the client that walks through your door, because not every client is the same, and there's a lot of variables that you can manipulate, and there's a lot of different factors to consider. So being on one side of the spectrum 24/7 may work well for one particular individual, but for another individual, being on the opposite side of that spectrum might be more beneficial for that person in that moment in time. So realize that there's 2 ends to the spectrum given any case, and there's always also going to be a middle point. Your ability to see both ends of the spectrum is important so you can understand where middle lies, but ultimately where you end up choosing to be for that particular moment in time could sway back and forth just like a pendulum from side to side. And this is the exact problem that a lot of continuing education courses do not allow you to do, because many of them are very, very biased. I put the Lord of the Rings picture here because, there's this one ring to rule them all. A lot of continuing education courses make you believe that it's this one specific thing that's going to fix everyone that you treat. If you go to a manual therapy course, likely that's a manual therapy technique that's going to make every one of your patients better. If you go to some other course that involves an assessment, they think their assessment process or their breakouts of a different movement pattern is the best way to always assess an individual given every single scenario. If you go to a course on breathing, they think breathing is going to be curing all the world's problems. If you go to a course on dry needling solves the world's problems. They draw you in. It gets you mesmerized in the fact that this one thing, if I just go to this one course, I'm going to be able to fix everybody that you treat. And realistically, that's just not the case. Then when you go back and practice these new techniques that you just learned and that the instructor gave you the viewpoint or the opinion that it's supposed to help everybody, and then you go back and practice it on people, and yeah, sure, sometimes you make people better, sometimes you make people better quicker, but then there's sometimes when the technique doesn't work at all, and then you're left from the standpoint of like, well, the instructor told me this was going to work, why is it not working? And you feel helpless at that moment in time because you feel inadequate, because you think that you don't necessarily know the material well enough to be having an impact on this particular individual, and you get lost in the complexity. A lot of times the courses are going to trick you into buying more and more courses, thinking you have to know more and more about this because we're going to go down this long rabbit hole of complexity, which ultimately just ends up muddying the waters and reducing your ability to make an impact on the individual because you're overcomplicating a lot of matters. You have to understand that continuing education courses are a business, and they're going to try to get you to buy more from them. Now, I don't think that many of the people in our profession are this used car salesman type person that a lot of us would think is scammy, but I do think many of the continuing education courses out there do have your best interests at mind, but the problem is that they remain very biased, and they remain very on one end of the spectrum, or they just discuss one thing. They never give you a bigger picture of how all these things interact. And depending on the individual that you treat, you need to be able to select the intervention that is going to be most beneficial for that person based upon their given circumstances. Now, I'll be the first to admit that, Sports Rehab Expert is a continuing education course from the standpoint of that is what our business does. So our business is prided upon the fact that we have courses that are there to help you out. Now, where we are different is we don't make you take a bunch of different courses, because we feel that oftentimes there are simplistic answers within a complex situation. So we help you see the simplicity into complex patterns, which is why at the heart of Sports Rehab Expert, all that we have is three main materials that we sell, which is 2 courses, an assessment course, a treatment course, and then a membership area, which allows for constant communication back and forth and your ability to ask questions and new material to be released based upon the questions that you ask, to keep giving you feedback to help you along the way, as opposed to just giving you a course and let you be hanging about how to implement that material in your practice given your scenario. So that's the purpose of the members area, is to allow you to ask questions to us, allow us to answer those questions, keep giving you content so that you can keep evolving, but ultimately have 2 main courses, the assessment and the treatment course, to go over everything that you need to know to be able to practice at an extremely high level. And then if you just want a little bit of taste of what all that looks like, we have the Sports Rehab Expert book out. Now, the Sports Rehab Expert book is going to go into a lot of the details that we talk about here. It's just going to dive into those details a little bit more in depth. It's a very light read, but it's a very informative read. It's a 250 some odd page book that you can get from our website, or you can get from Amazon. But more importantly, before we get into this presentation, is I just want you to be relieved a little bit more so from the standpoint of, we pride ourselves on being very unbiased in our opinion towards continuing education courses and towards assessments and treatments as it relates to physical therapists, athletic trainers, strength and conditioning professionals, and chiropractors. So diving deeper into these 12 stereotypes, The first one we're going to be discussing is the manual therapist. This is one of the biggest stereotypes that I see out there. And when you look at a manual therapist, whether that's a manipulation course, a massage course, an active release course, it's a instrument assisted soft tissue mobilization course, whether it's a dry needling uses an implement, instrument assisted uses an implement, but the majority of these courses give you the feeling that you can solve problems with your hands. Now that should just raise some flags with you right there, but the first thing that I want to draw out is just a couple areas in the body that many people think that they're treating when they're performing some type of manual therapy. So you'll hear a lot of manual therapy first rib mobilizations, quote unquote, or manipulations, or setting the first rib back into place, or the first rib is out of place. But if you look at the first rib and truly look at the anatomy of it, and what textbooks would tell you is that it's a synarthrosis joint. And if you break the word synarthrosis down, you get the word syn. Syn means without. And if you break the word arthrosis, and if you look at the word arthrosis, that means joint. So that word literally means without movement. And if you look at the body, you can just see how difficult it is going to be for that joint to move at all, just because it's such a strong piece of tissue that connects right to the sternum. So the ability for you to adjust it, set it back into place, or manipulate it is damn near impossible. So we need to stop thinking that if potentially we put pressure on the first rib and somebody feels better, that it's actually us putting something back into place. We need to reframe that, and we'll talk about that more in just a moment. That goes into the other side of the coin, the other side of the picture that you need to be considering. Same thing with the IT band. A lot of people think they're going to stretch it or massage it out and make it looser, but realistically, the IT band, there's been research to this, and it takes about 2,000 pounds of tensile force to actually lengthen it. So do you think by massaging it or using an instrument or using your hands or stretching it, you're actually going to lengthen that piece of tissue? No, you're going to have to put a car attached to somebody and have the car dangling from their leg in order for you to get any type of lengthening to occur in that tissue. And likely the joint's capacity to be able to withstand that traction force is going to give out before you reach a point of being able to lengthen that piece of tissue anyways. And the same goes for scar tissue for that matter. So this is one side of the equation where we have people who think that they can solve problems with their hands. Now, I'll be the first to admit also that there are many times when perform a manual therapy technique and that person got better within 1 to 2 sessions. So possibly there's something going on there. We just don't know exactly what. Just to kind of reiterate this point a little bit more, this kind of goes along the lines of any type of muscle energy technique. They're gonna, line your hips up perfectly, have you perform the shotgun maneuver, and you look perfect on the table. But then the ironic part is I'm just gonna have you stand back up and walk again. And realistically, when you look at gait is moving joints in and out of what someone would consider a neutral position, because we're moving on to the right leg, we're moving on to the left leg. The spine is going to move back and forth, the hips are going to move back and forth in alternating and reciprocal action. So there is no perfect alignment, there is no one set alignment, because as soon as you start moving, your alignment is going to change as you move, and that's perfectly normal. It's 100% needed and necessary. We'll get into alignment a little bit later, but just to reiterate the fact that why muscle energy techniques aren't necessarily going to be the be-all end-all for a person is just because of this matter, because as soon as they get up and walk and move, their joints are going to move with that too. Now, having said that, has manual therapy worked to modulate somebody's pain in the past? Certainly it has, and likely you've done it in the past as a clinician too. If you've done any type of manual therapy or muscle energy techniques, likely you've had success with it before, which is why you keep continuing to do it, but likely it's also limited in how effective it is for every single one of your patients that walks through your door. That muscle energy technique is not going to work for every single person, so you have to know when it may or may not be useful. Same thing with the manipulation. If you manipulate everybody that walks through your door, chiropractors would have this world in the most healthiest state the world possibly could be, because you go in, you get your 7 cracks, and you walk out in a matter of 10 minutes. And if a manipulation was going to fix everybody, then chiropractors would have had all of the world's problems solved at this point in time by now, because they've been doing it for years. So yeah, manipulation has helped people in the past. It's helped relieve pain quickly, but due to the amount of people who are still in pain in this world, obviously it hasn't solved all of the world's problems at this point in time. So likely it's necessary that you have to broaden your horizons and understand when a manipulation is or is not going to be useful. So that's where this third side of the coin comes into play. You have to know where the two extremes are so that you can stay somewhere in the middle and then bias yourself towards one end of the spectrum based upon what is needed and necessary for that individual. So manual therapy certainly can be useful to assist somebody in decreasing their pain when applied appropriately, but we have to admit to ourselves that we're probably working on a non-specific level, and mainly it's just sensory and neurological, as well as potentially meeting client expectations. This is a whole topic in and of itself, but to my opinion, placebo isn't necessarily a bad thing, because we use this all the time. We use it from a standpoint of, yeah, some of our treatments may be a little bit placebo related as far as us getting results, but how we interact with that patient is also a placebo in and of itself too. I've seen this many times before, and you likely do this as a clinician yourself. If a patient asks you, am I going to get better from this? Likely you're telling them something along the lines of, I've seen this knee issue before. I've helped many people with the problem just like you out before with a very similar issue, and they've gotten back to doing what they love and enjoy to do. So I'm confident that we can help you do the same. That very much is a placebo statement. You don't know 100% that you're going to make that person better, but you just made them feel a lot more comfortable that you've treated this in the past and that you can help them. So now they're going to be a little bit more at ease. They're going to be a little bit more comfortable with your treatment. They're going to trust you a little bit more. They're going to have a little bit more buy-in and follow through with your treatment plan of care. And likely you're going to get better results. But you used a placebo statement to help get you to that point in time. So is a manual therapy that maybe is a little bit of a placebo impacting that individual a bad thing? I would say not, so long as it's framed in the right manner to not force the individual to rely on that treatment for the rest of their life, and they move on to other treatments that give them a locus or internal sense of control about the issue, as opposed to relying on you as a clinician to help fix them all the time. So it's all about how you pre-frame that. And when I'm considering manual therapy and whether I use it or not, or whether I lie on the end of the spectrum of this is going to be very helpful for that person or this is not going to be helpful for that individual at all, how I view the edge of that, how I view the third side of the coin, as manual therapy can be a crutch or an assist. And we use crutches all the time to allow partial weight bearing to keep normal gait pattern instead of using extreme compensation. We also provide those assists in the form of a sit-to-stand transfer for somebody, say min assist 1, very common terminology that's used in the physical therapy realm with an elderly population. Going from min assist to 1 to contact guard assist is considered progress, or say finishing a rep on the bench press from a strength and conditioning standpoint. Maybe that person can't do 225 for three reps yet, and on that third rep they need a little bit of assist to be able to get that back up. We're perfectly fine in giving that individual some type of manual assist when it comes to some type of strengthening activity, but why is an individual's psyche or why is their sensory system not the same? Why can't we not provide that system a little bit of an assist to help provide us the ability to move forward to bigger and better things? Furthermore, manual therapy does not have to have a physical change to occur in order for improvement to be made. Again, we already admitted to the fact back here that likely it's impossible to create some type of physical change when we use our hands. So it's more than likely, again, going to be sensory as far as how the impact that treatment has on the individual. And to a certain extent, we've already kind of confirmed this from MRIs, X-rays, and different tissue studies where we see that pain does not have to necessarily correlate with structural damage. So if pain doesn't have to correlate with structural damage, why does all of our treatments have to correlate exactly with making some type of structural change? Again, there's more systems to consider, and as long as you're trying to instill some type of internal locus of control of the individual about their pain, give them a sense of control about the issue, manual therapy is perfectly fine to to utilize as a crutch or assist to move on to bigger and better things. But it's certainly not the be-all end-all, and depending on the individual, you're going to have to sway, you're going to have to move from that spectrum side to side based upon how much you think is necessary for that individual to make progress. But you should not lie on one end of that spectrum 24/7 with all of your patients that you treat. Now the next stereotype that I want to bring up is the exact opposite of what manual therapists tend to believe. So a lot of people who view themselves as manual therapists likely don't necessarily always do a lot of strength and conditioning stuff. Likely a lot of rehab professionals or strength and conditioning professionals pride themselves on some type of exercise as far as making the individual improve. So there's this conflict between exercise versus manual therapy. So I want to bring this one up next for the purpose of getting you to view the three sides to this coin as well. I see this in a lot of research junkies, a lot of people who look for histological or tissue studies that show some type of structural change happening from an intervention. Again, pain doesn't have to correlate with tissue change. So why do we think tissue change needs to occur in order for everybody to get better? Now, creating tissue change is certainly a very useful thing to try to do for somebody, and it could definitely help a lot of people out, but it's not going to be able to fix everything. Believing that eccentrics and strength and conditioning is going to fix everything is going to really limit your impact as a clinician. So you need to still be able to empathize with your patients as well too. Now, I'm not going to deny the fact that eccentrics can be very, very useful. There's a lot of qualities that you're training when you perform an eccentric activity, such as strength, hypertrophy, flexibility, because you're working that tendon in a lengthening or eccentric state, so you can actually improve flexibility with eccentrics. You can certainly improve work capacity and confidence as well too. So there's a lot of benefits from working eccentrics. However, we cannot forget the other trainable qualities that are not considered with eccentrics. So from an exercise standpoint, we also need to consider positional variability. That is not trained with an eccentric. Very little gross movement and local joint movement options are considered with these big global exercises, such as a squat, such as an RDL. All very useful activities to drive strength, hypertrophy, flexibility, work capacity, and confidence, but it doesn't necessarily look at the little gross movements or local joint positions and how that eccentric was actually accomplished. So we still need to look at the actual movement and the coordination within that movement as well too. The best example or analogy that I have for why positional variability in joint position is important is this analogy of a hardwood chair down here, and the analogy of how pressure influences pain. If I was to tell you to sit on that hardwood chair and you're going to do that for 24 hours and you cannot move, you have to sit perfectly still, you can't shift from butt cheek to butt cheek, there's going to be a significant amount of pressure and compression that occurs to the glute, to the vascular system, and at some point in time that becomes very uncomfortable, perhaps even painful for that person to sit down there. Now we know no tissue damage occurred from sitting there for that extended period of time for 24 hours, but we know that it became very uncomfortable or perhaps even painful because I didn't allow you to shift pressure around from butt cheek to butt cheek. And that's exactly what variability is, and what the benefit of variability does is it allows us to shift pressure so that pressure and stress does not accumulate over an extended period of time. If we are not variable, then pressure and stress is going to accumulate, perhaps in one particular area more than another, based upon how that individual moves or has a tendency to move. So we need to make sure that we consider that. We're going to talk about this more in a future stereotype, because there's a stereotype for positional variability in and of itself as well too. So don't lose sight of that. We'll come back to that. Just remember though that it is the opposite side of the coin for someone who is very, very strength based. Now, someone who is always also very strength based, we also need to understand that dynamic movement is not often considered with just eccentrics. We're working tissue capacity, tissue qualities when we work eccentrics, but we're not actually working coordination of movement as it's specific to the task that the individual might be doing. So if, say, this is a basketball player, the ability to run and jump and effectively decelerate their mass and momentum and transfer it vertically. So if I'm running and jumping and trying to do a layup or a dunk, I'm moving I'm creating a lot of horizontal momentum that I have to transfer all of a sudden vertically. And the ability to perform that dynamic movement efficiency and do it efficiently is a skill just like running and jumping. So there's a coordinative element that goes to it as well too. And if the individual does not have coordination over their center of mass, over how to manipulate their center of mass in a dynamic fashion to be able to apply forces in the correct direction at the particular moment in time that is most optimal for said task, then that can lead to a less than efficient movement pattern and potentially more stress accumulating both in the short term acutely when they perform that task, but a long term if they perform that task the same way over and over again in a less than optimal fashion. So if you're always focused on eccentrics and changing some type of histological tissue, you're missing the boat on other very important trainable qualities that could be useful in a treatment plan of care. Furthermore, if all that you do is eccentrics, you have to understand that everybody that walks into your clinic or gym is not going to be able to tolerate a supramaximal load. Eccentric is just one function of a muscle. You can't forget concentrics and isometrics as well too, because in the ability to co-contract a muscle in moments of times and need for force transfer and stability purposes. So we have to train a variety of different muscle contractions so that the individual can use the correct muscle action based upon the task that they're trying to perform. Just to piggyback off of this stereotype a little bit more, there's a third stereotype out there, number 3, that you can't go wrong with getting strong. And this is the irony of workload monitoring and work to rest ratios, is that we do all this monitoring to track workloads, both from an acute standpoint, but then also from a chronic standpoint over the course of a season. What does their workload management look like? But rarely do we consider how the exercise is performed. So yeah, sure, it's certainly useful to get someone strong and get someone performing squats, deadlifts, but how are they actually performing that task over the course of an extended period of time? Do they constantly dump their pelvis down into a rounded position as they squat down? Obviously, this is one extreme position that we would never want somebody to squat in, but there's also this hyperextended low back posture with the head up and driving someone into a lot of extension. And that would be the other side of the equation there, is that if we're always driving someone into this extension posture 24/7, that can lead to its own set of problems too. There's flexion-based pain, low back pain, and there's extension-based low back pain. And depending on how we perform a task, how often we program that task, might be reasons why somebody develops flexion-based back pain or develops extension-based back pain. Again, think of the positional variability hardwood chair analogy, is that if you can't shift pressure, if you don't have the capability of both movements occurring, if you don't have the ability to shift butt cheeks and you always perform a task the same way over and over again, you lose your variability and you lose your ability to distribute pressure. So now, while the squat, from a standpoint of 3 sides to every coin, you may not want a loaded squat to really look like either end of the spectrum. And in this case, you might bias yourself more towards the middle of the spectrum, or trying to get yourself somewhere in the middle as opposed to lying on the outliers of either equation. That might be the best route for you to take in this scenario as far as teaching someone to squat. Yes, I know that it's impossible to achieve a neutral position, but you're trying to get somewhere as close as possible to neutral as you can during that loaded movement to keep someone safe. And then when you do some other type of movement, maybe you're training some type of flexion-based movement with some type of sit-up variation, Turkish get-up variation, or toe touch variation. You're still training that flexion-based movement pattern. And then from an extension standpoint, maybe you're still training a GHR, or maybe you're still training a reverse hyper, or some type of extension-based movement pattern as well too. Doesn't mean that you have to never train extension either. It just means from a heavy loaded squat standpoint, we're going to try to bias ourselves somewhere in the middle. Now, again, it's all on a pendulum, it's all on a spectrum. That could be on either side of that edge of the coin, but we're not going to want to stay on one extreme for very, very long as it relates to a loaded squat, especially if we're programming it frequently in an individual's program. So what we might do is we'll still program that squat, but stay somewhere a little bit more centered in the extremes of flexion versus extension, but then in that program, we'll subsequently also perform flexion-based movements and extension-based movements to keep an individual varied and keep the ability to stay and keep variability high within their program as well too. So if you ask me the question, can you go wrong with getting strong? I would say absolutely 100% yes, because there's many times that I've seen people come to me because they just didn't program or they didn't perform an exercise correctly. So if you don't know how to get strong correctly, meaning correct programming, correct technique, then certainly trying to get strong can induce a lot of problems. And that's the third edge of the coin here with this particular statement is, yes, you can go wrong with trying to get strong if it's programmed poorly, both from a sets and rep schemes and a rest scheme, but then also from not having enough variability within that programming between movements. And then number two, what does the technique of an exercise look like? So an individual could be doing the right thing by trying to get stronger, but if they don't do those two variables correctly, then they may actually be putting themselves at a little bit more risk for injury by trying to get stronger too. So you have to consider both ends of the spectrum to put yourself in the middle so that you can view which end of the spectrum you're going to bias yourself for that particular individual who walks through your door with their particular set of problems. And you can't bias everybody into just doing one thing. Now, I put all these in a particular order for an exact reason because the next one I want to bring up is this stereotype of a movement specialist. This is an individual who will constantly tell you, don't put strength on dysfunction. We have to get everything looking picture perfect before you load somebody. And the ironic part about that is this individual never actually gets to loading or creating a training effect on somebody or an adaptive stressor because they're so concerned about perfect form. Now, as I mentioned in the last stereotype, biomechanics matter greatly, but we have to also ask ourselves to what degree. So there's going to be a minimum level of competency before you start to squat somebody. You don't want the squat looking like this. This squat might not necessarily be a bad thing and certainly is more trainable. I would like someone to be biased towards this end of the spectrum more so than this end of the spectrum if I was loading a squat, but this squat could certainly produce some type of extension-based low back pain with the amount of hyperlordosis that's going on with that individual if done over an extended period of time. So yes, we want to keep optimizing that squat, kind of get them to feel their abs a little bit more, create a little bit more neutrality, but then again, remember, neutrality is on a spectrum in and of itself. There's no exact point of neutral. There's just going to be a spectrum of neutral, and we want to bias this individual somewhere towards the middle when they're loading a squatting pattern, but realize that every rep that they do of the squat is going to be a little bit more flexed or it's going to be a little bit more extended, and it's perfectly fine to have that slight variability. We just don't want these big sways and extremes to occur. So there's going to be a minimum technical proficiency that is necessary and needed before you start loading somebody. But once they meet that minimum level of technical proficiency, then you have to start loading somebody to start creating a training effect and start creating adaptive stressors. Perfect. I think this quote summarizes this stereotype perfectly, is that perfection is the enemy of progress. There's a minimum technical proficiency level, that you want to be very adamant about. That's one side of the coin. You want to be very, very technical. You want their technique to look great, but there's going to be a point when they reach the minimal technical proficiency where it's okay to take yourself to the other end of the spectrum and start strengthening that individual a little bit more. But careful you don't move too far in that direction and you start to forget about technical proficiency. You start to forget about programming. Again, there's three sides to every coin, and this is all on a spectrum. And based upon what that individual needs, whether it's a little bit more technical proficiency or it's a little bit more strength and capacity, you're going to have to bias yourself to one end of the spectrum a little bit more so than another. But depending on that individual may need more technical proficiency and more variability, but that individual may need strength a little bit more. So depending on that person that walks through your door, and that's why it's important to do a needs analysis and a profile, creating a player profile, something that we talk about in Sports Rehab Expert book and in the programs, creating a player profile that lets you decide what qualities you need to emphasize the most with any given individual that walks through your door. Now, just to summarize this a little bit more, if you ever take a course with the Sports Rehab Expert certification process, you'll see this slide here over and over again because I think it's really, really important. You have to learn by doing. This goes from your standpoint as a clinician and improving your clinical skill sets, but also from a standpoint of getting an individual better. Is if you never do, again, because you're so concerned about perfectionism, if you never do, then you cannot ever reflect on how that went and conclude what to do differently in the future. And this is an ever evolving process that will occur back and forth. Perfectionism is the enemy of progress. It's okay to be good enough. Good enough allows you to challenge yourself. It allows you to experience adversity, a challenge, which is what leads to progress. So at some point in time, you're going to have to load an individual to make them better and to make them stronger and more resilient. If you're always focused on movement, then you're just going to always stick to body weight or very, very low levels of resistance and not actually build resiliency and capacity up in that individual. So we have to not be afraid of loading somebody, but we have to also have a minimum technical proficiency standard that we stay tried and true towards. And there's no better example of this than, say, a powerlifter. Powerlifter at some point in time, say they currently can do a 500-pound squat, something the majority of this world would not be capable of doing. But for this powerlifter, they're capable of doing 500-pound back squat. Now that 500-pound one repetition back squat, that might be a new PR for that individual. Likely that the technique of that exercise is not going to be perfect. We're not going to expect perfect technique when they're under this extreme amount of load. So if you're allowing some variability in how the exercise or technique is performed under a one repetition maximum, or say they perform 10 reps at 225, but that 10th rep, because of fatigue, they started to lose form a little bit on that rep too, that's perfectly fine. It's perfectly normal to lose form, lose technique as fatigue or as the strain levels start to increase. Again, we just don't want to spend the majority of our training time in a position suboptimal for that amount of load. But for one lift, for one rep, it's likely not going to make a difference. So the next stereotype is going to be neutrality warriors. And again, we put these in a certain order because I want to prove a point when we're talking about all these stereotypes. Just like in our 500-pound back squat analogy, again, we would like the individual to stay at neutral, but more than likely, if they're performing a PR or they're performing multiple reps under fatigue, they're not going to stay in neutral. And realistically, to expect every movement to be the same over and over again, it's just not going to occur. And this is the ironic part about somebody who performs some type of alignment assessment or some type of intervention that on the table, quote unquote, puts someone back to perfect alignment. It's that when we walk, there's actually going to be a change in alignment that occurs 24/7 with every step that you take. So there's actually going to be a little bit of a scoliotic curve that takes place with every gait cycle. You're going to have a little bit of dip in the hips that occur when walking, and you're going to have a little bit of dip in the shoulder that occurs with walking. There's going to be rotation, thorax rotation towards the stance leg. So there's a lot of movement in the joints that will occur during a gait cycle. And then for them to get on the opposite leg when they're walking, they're going to have to reverse and perform the exact opposite of that. So the individual never stays in a perfect set alignment when they're walking, which is the most functional thing that an individual can be doing because they're doing it their entire life. Just like when you look at neck range of motion, you look at right side bending, right rotation. You also look at left side bending and left rotation. And the individual needs to be able to perform both just equally as well because they're going to have to experience both. And if they can't side bend left or they can't side bend right, then they need to develop those qualities or that ability to do so in order to stay variable in their movement capabilities. And if they can't stay variable in their movement capabilities, then problems subsequently will start to ensue. So if someone is keeping one alignment 100% of the time, that individual is not very variable in their movement. And if they stay in that alignment 24/7, likely it's going to cause problems. Again, same thing. There's no better example of the three side of the coin equation here than this is if we move, there's two ends of the spectrum. This is one side of the coin, this is another side of the coin. Neutral is somewhere in the middle. We have to have the ability to move right, and we have to have the ability to move left. And we also need the ability to stay in the center or on the edge of the coin. But our ability to experience both ends of the spectrum allows us to get a better sense of what center or neutral is because we've moved away from neutral and we've experienced both extremes before. But all of this is on a spectrum. We're not going to stay in one particular extreme longer than another extreme. We're going to want to move back and forth between extremes and sometimes spend some time in the center. But one position isn't necessarily more valuable than the other position. What's valuable is your ability to achieve multiple positions and experience all the different movement capabilities that the body has at its disposal. Now, stop me if you have heard this one before. There's a lot of flexion-based feared therapists or strength and conditioning coaches out there is that flexion is the devil. Anything flexion related is a problem. Then there's also people who think that extension is the devil. They think that everybody is extended and that they can't ever experience extension because extension is the problem, or flexion because extension is the world's problems, or flexion is the world's problems. My question to either one of them is, why can't we just do both? If you could do both, then you would spend less time in one position and become more variable because you can achieve a variety of different positions. I really don't care if someone gets into this position. Now, at certain pain presentations, that position may influence somebody's pain or make their pain more sensitive or increase irritability of those tissues. But same thing here is I don't have a problem with someone standing in that position, but if someone does that and that's all that they do, at some point in time, that's probably going to lead to some type of pain presentation as well. So the problem isn't necessarily that flexion or extension is bad, it's when everything becomes flexion all the time, every time, and the bias for them to hold themselves in that posture when they're staying static is flexion too. So when they move, they're always flexing, and when they're staying static, they're always flexing. Same thing with extension, is when they move, they're always hanging out in an extension-based pattern, but when they're static too, they're also hanging out in an extension-based position as well, and they've never experienced the opposite. I've seen plenty of people who have pain when they stay in this flexion-based posture all the time, every time. And I've seen plenty of people who stay in this military upright posture all the time, every time. Both of them have the right and the ability to experience pain by being in that position all the time, and both of them have the right to move away from that posture, and both of them have the right to move away from that position anytime they would like. The problem is when it becomes a tendency, meaning there's no positional variability. Again, remember the hardwood chair analogy. You have to be able to shift butt cheek back and forth to redistribute pressure. And if you can't do that, then pressure will start to accumulate, and pain and discomfort will start to accumulate. And just like with the neck, we have to be able to right side bend and left side bend. You would expect the neck to be able to flex and the neck to be able to extend. So why can't our low back flex and extend? Why can't it achieve side bending in both directions, rotating in both directions? All those motions are necessary to remain variable so that we can shift from one butt cheek to a next butt cheek, so we don't end up in this hardwood chair situation. Which leads us perfectly into the next stereotype, which is the posture people. And you've all heard these individuals before, is, sit upright, stand upright. Imagine like a string is attached to your head and you're pulling yourself vertically and you're making your body long as possible. How exhausting is it to just think about doing that all the time? Remember our talk about neutrality. There's no perfect posture. Posture in and of itself is a static word. So if we're talking about posture, we're talking about a static human being, which a static human being is not necessarily a healthy human being either. We are moving individuals. We are meant to move and stay moving. It's impossible to stand still. It's actually even impossible to stand still, which is something we all know and would refer to as postural sway. If you told someone to just stand, cross their arms, and stay as still as possible, what you'll still see is there's a measurable sway left and right and forward and backwards. This is normal. This is because the body is meant to be moving. So we're actually constantly moving 24/7, and we cannot remain perfectly still. And that's a good thing. Again, going back to the hardwood chair analogy, is we want to be able to be variable and shift pressure around. Now there becomes certain moments in time when we might become too variable, where we have a significant amount of sway occurring, or that because we don't necessarily know how to control our center of mass or control our postural sway, we might bias ourselves into one particular movement strategy more so than another, and that's where potential problems could ensue. But ultimately, posture is very dependent on the task and the contest. Think about dunking a basketball. Dunking a basketball, the position necessary to do that is very different than picking a pen off the ground or, say, bowling. Posture is context dependent and it's task dependent. And our ability to achieve multiple postures allows us to be able to accomplish a lot more tasks in our life. So then you might ask a question, well, what about symmetry? Are we always trying to move towards symmetry within our movement? Or what about the whole asymmetrical talk? I hear a lot of people talking about how our diaphragms are a little bit different, our internal anatomy is different. Should I be worried about asymmetry? So this is the next stereotype, this symmetrical asymmetrical confusion. Is you need to understand that our internal organ anatomy is normal because it actually is asymmetrical, and that is fully 100% normal within the body. We have a liver on our right and a heart that pushes down on the left diaphragm. So there actually is a difference in the height of our diaphragms, which leads to biomechanical differences within the respiratory system. Neurologically, we're also wired differently, left versus right. The lymphatic system is different, left versus right. There's more lobes of lung on the right side than the left side. There's a lot of asymmetrical internal organ anatomy things that are going on within the body, and that certainly will impact our movement. some people take this way too far to one end of the spectrum again. They think that we only need to be able to perform certain exercises on one side of the body as opposed to the opposite side of the body. But you have to realize that the body is much more resilient to stress, and the body, if a certain exercise would cause problems on one side of the body and not another side of the body, then our body, you're just telling yourself that you're not a very resilient human being is if you can't perform exercise on both sides of the body. Again, think about the whole neutrality talk, is that we need to experience both ends of the spectrums to be successful in the tasks that we want to be able to do. We don't want to bias towards flexion. We don't want to bias towards extension. We should have both. We need right side bending, left side bending. We need right rotation, left rotation. So why does it matter that things are asymmetrical? When we move, we still want to train the body to move to both sides, because we need to experience both sides of the spectrum to know what center is, and then bias ourselves towards one end of the spectrum depending on the task that is at hand. Your body is not made of clay. Some type of manual therapy input is not going to change tissue length or tissue structure, nor is performing one exercise on one side of the body going to be harmful to the human body either. They should be able to perform that exercise on both sides of the body. Now, depending on that individual's tendency to bias themselves in a particular position all the time, you may want to emphasize one side of the body a little bit more than another side of the body. Symmetry and the ability to move in the same way to the right and in the same way to the left is the goal. So instead of looking this one from a lens of is symmetry good or is asymmetry good, realize that both are normal and necessary. Our body is asymmetrical, which is what makes us human, but a lot of our tasks are symmetrical tasks, or we need to be able to do the same thing on the left side as on the right side. So symmetry was never the goal. Sure, it may look aesthetically pleasing, and Leonardo da Vinci may have fooled you with his artistic capability, but the goal was never symmetry. The goal was moving competency, so we can achieve many different postures, so we can left rotate, right rotate, flex, extend, perform gait on both sides of the body equally as well, and be able to coordinate that back and forth so that we can be a reciprocal and alternating human being, and then develop strength and capacity on those movement qualities so that we have strength, both body and mind, resiliency, both body and mind, physically and emotionally, and then hypertrophy, as well as endurance to build that body armor up. Furthermore, having an asymmetry has not even been a good predictor of injury or pain. And in fact, asymmetry can actually be desirable in a sport. So say a baseball pitcher who has more shoulder external rotation and less shoulder internal rotation on their throwing arm. I would expect to see that on a table assessment. And if I did not see that, then I might actually say that the potential lack of that asymmetry is actually putting somebody at risk for injury for that particular sport, because that sport benefits asymmetry. So the better question is, how well does someone manage their asymmetry or their tendency? Can they have an asymmetry when it's necessary, but then when they're resting and just performing daily movements where we need to be able to alternate and perform reciprocal and alternating movement equally as well on the right and the left, can they do that when it's necessary? Can they manage their tendency and not bias themselves towards their tendency 24/7? Same thing with the flexion, the extension postures. We should not bias ourselves into flexion all the time. We should not bias ourselves into extension all the time. We need to be able to experience both, and we need to be able to manage our tendency, whatever our tendency may be. If we have a tendency to bias ourselves towards extension, we need to learn how to bias ourselves towards and move into flexion on occasion. If our bias is towards flexion, then we need to be able to move and bias ourselves towards extension at some point in time. We need to remain variable in our movement, and we need to be able to remain to have the capability of performing reciprocal and alternating movement. Now we're coming up on the last couple stereotypes. This stereotype is another common one that I see, particularly in the rehabilitation room, is stability training. What we commonly think of stability training is not actually doing what we're trying to accomplish. We think we're performing stability training by standing on an AirX pad or standing on a Bosu ball. That's going to work our stability, right? But we forget about what the foot is actually capable of doing and what it's designed to do. The foot is designed to accommodate to the surface, and the foot is designed to interact with gravity and the environment. Our foot does this, number one, to be able to ambulate efficiently, and number two, to be able to accommodate to unlevel surfaces. This picture here on the left. The foot was not designed to walk or stand on a spongy or bouncy surface that we so often think we're challenging balance and proprioception to train stability. The foot, again, is going to accommodate itself to the surface at hand. Then there's going to be individuals who think now that they all of a sudden need to do everything barefoot. Now, barefoot can be useful at certain points in time because it takes the earmuff off the feet and allows us to sense the ground and feel how the foot accommodates the ground. But we also need to admit the fact that we live on mostly flat surfaces too. So unless you're going out in the environment and walking out in barefoot and have experienced that time and time again, and if you have never experienced that before, you gradually expose yourself to that. You don't go full bore into it right away. You have to gradually expose yourself to these things if you've left this out of your life for an extended period of time. But the majority of life is on flat surfaces. Think sidewalks, think cement, think pavement, think carpet, think ground. The majority of surfaces are flat, whereas the foot, again, was designed to interact on unlevel ground to accommodate to those surfaces. So if you're always acting on flat ground all the time and never accommodating to an uneven surface, then your foot is probably not as adaptable as what it's capable of being. Furthermore, if you go out and try to walk barefoot on some unlevel ground, likely an injury is going to occur because you haven't experienced that in a long, long time. So we need to ask ourselves what stability training really is. And stability training is the use of these three systems right here. It's the vision, vestibular, and proprioception. And when you consider all three of them, we have 100% utilization. There's going to be no more, there's going to be no less. So I have 100% full pie chart capability of using those three systems. Now I might choose to break these systems up evenly, where I'm using the vision, vestibular, and proprioception system evenly, or I might choose to use one system a little bit more so than another, depending on what I'm good at or what the task or the environment demands of me. So if I close my eyes, now I'm relying on 50% vestibular and 50% proprioception from my foot in the interaction with the ground. Or if I'm walking in the dark, this is what it requires. Now, say I have an inner ear problem. Now that's going to put more onus on the vision and the proprioception to take place. Or say I have a visual impairment. Maybe I'm only using 10% of my vision. That's going to impact how much the vestibular and how much the proprioception is going to be necessary and needed to keep yourself balanced. So I can't have any more than 100% utility. Now I certainly can have less than 100% utility. Say my vision is impaired. Say my inner ear is impaired. And say I don't have very good proprioception or ability to accommodate to the ground with my foot. I can certainly have less than 100%, but I cannot have more than 100%. Now, what you need to realize is that if you're standing on a foamy or a bouncy surface, is that surface is going to actually impede the body's ability to feel the ground. It's going to actually impede proprioception. There's no better example of this than the foam and dome test in the physical therapy world, where we use foamy surfaces, we use a bouncy surface to impede proprioception. So if we're impeding proprioception, say we can only use that 20%, just an arbitrary number there, now that puts more onus on the vestibular and the visual system to go 40% total to equal 100% total there. So if we're standing on a Bosu ball, or if we're standing on a foamy surface, we're actually impeding proprioception, and we're forcing the vestibular and visual system to work harder. So how is that actually going to improve our proprioception? It's not. And that's the big myth that is out there. Now, the way you can improve proprioception is you force it to work harder, such as by closing the eyes, because that's the easiest, is to just take the visual system out of the equation and force vestibular and proprioception to work harder. It's kind of hard to take the vestibular system out of the equation. So one of the simplest ways that you can manipulate proprioception is by making proprioception work harder. You do that by closing the eyes, or you do that by reducing the base of support, or challenging their center of gravity, their center of mass to work harder, or you actually have them on an unlevel surface that forces the foot to accommodate to the ground and have more sensory feedback, then put them on a foamy or a bouncy surface that would impede their proprioception. If you're impeding proprioception, you cannot make proprioception better. That would be the equivalent of saying you're going to impede your vision by putting on a mask, and your vision is going to get better. Or putting on an eye patch in your eye patch, or putting an eye patch over your right eye, and somehow your right eye is going to get more visual acuity from that. It just doesn't make sense. So why do we think that impeding proprioception is going to improve proprioception? We need to find ways to make the proprioception system work harder, and how to challenge the proprioception via base of support, via challenge and center of gravity, via closing the eyes, or forcing the foot to accommodate to ground like it was designed to do. It was not designed to try to accommodate to a foamy surface or a bouncy surface. That's not accommodation. An unlevel surface is very, very different than foam or a bouncy surface. Breathing buffoons. This one I gotta laugh at a little bit. This one's becoming more and more common in the rehabilitation world, and becoming more and more common in the strength and conditioning world. The people who operate on one side of the equation don't think that breathing really has anything to do or any place in rehabilitation or training. They think it's all fluffy and foo-foo. But what they fail to realize is the other side of the coin, which is where the respiratory system has an extreme impact on cardiovascular physiology and ability to reduce stress. So pH level, the ability to shuttle blood, pH buffer, or variability of acidity versus basic based upon physical stressors, sympathetic versus parasympathetic. The respiratory system is unique from the standpoint is that it allows us to interact with all the different human systems of the body all at once. It also has a very biomechanic way of manipulating force, manipulating pressure, and manipulating center of mass, because it's one of the most central structures. So we have bucket handle motion, and we have pump handle motion. There's going to be inhalation and exhalation, inhalation and exhalation. And that movement is going to influence spinal curvature. It's going to influence rotation, both in the transverse plane and in the frontal plane, and in the sagittal plane as well too. One of the easiest examples is, think about the rib cage right here and the spine that the rib cage attaches it towards. If this rib cage is fully pump handled up on inhalation and bucket handled out in inhalation as well too, we have a lot of air volume that is within this thorax, and this air volume is going to restrict the ability for the spine to flex, or the rib cage to retract and depress to allow spinal flexion to occur. So air pressure will also facilitate movement. The biomechanics of the respiratory system will influence movement, both from a pump handle and bucket handle standpoint. the spine, the pelvis, the scapula, that all extend outward from the trunk of the tree, which is the rib cage. The appendages are the extremities, or the branches that extend outward from the trunk. The position of those extremities or those appendages are all going to be very dependent on what's happening at the trunk or at the thorax. So there's going to be a lot of biomechanical influences of the respiratory system. There's going to be an air pressure influence of the respiratory system, and there's going to be a physiological impact of the respiratory system. So the respiratory system is not something to ignore, it's something to embrace. But again, if you're only emphasizing these low-level breathing exercises all the time, you are, to a certain extent, performing some type of floofy, foo-foo exercise, and you're not actually getting into adaptive stressors that is necessary to create more resiliency and capacity. So you still have to strength train the individual, but there's also ways of strength training with keeping the respiratory system in mind. And that's really the next level of clinician that we do a ton of talking about that in Sports Rehab Expert, in addition to everything else that we've talked about in the Sports Rehab Expert certification. We do a ton of teaching you how to not just stay with these floofy, foo-fooey respiratory exercises. We get you to think about how to include them into actually training somebody and actually getting an adaptive stressor, but also keeping in mind benefits of the respiration system as well too, and again keeping in mind all these different stereotypes that we've talked to up until this point in time, and how to avoid biasing your treatments one way all the time 24/7, and being able to recognize when a particular treatment strategy, a particular intervention strategy is going to be more useful for a pain presentation than another pain presentation, and to be able to choose what particular intervention strategy is most useful depending on the pain presentation that is in front of you. Just a couple other words on this category, this stereotype, the breathing buffoons, is that a lot of people, again, they get way too caught up in the complexity here, and they forget to also train somebody too. So again, you want to avoid fixating on one thing or thinking that things have to be perfect. Again, avoid all the same traps that fall into the manual therapy, the technique, the perfectionism category, or the posture people category. You need to avoid all those same fixations or all the same problems or biasing yourself on one end of the spectrum. You need to understand both sides of the coin so you can know where the center is or where the edge of that coin is, so that depending on the person that is walking through your door, you can bias your treatments in a fashion that's going to be useful for that person at that point in time. Stereotype number 11, we're getting close here. This is the muscle confusion enthusiasts, and this is the individuals who think they need to prepare the body for anything that life might throw at them. So they're always changing up their exercises. They think that variability is the spice of life, which to a certain extent it is. But you also need to be doing the boring, repetitious stuff because to a certain extent you have to have a repetitive stressor to build adaptation. So while it's certainly important to vary things up occasionally to keep the body guessing, you can't keep it guessing so much that it doesn't actually impose adaptation to occur. So there has to be a balance that occurs. You have to be able to perform exercises on a repetitive basis to actually get stronger, and you can't keep changing up the activity over and over again. But to a certain extent, like we've talked about with the whole variability concept before too, if you perform that same exercise over and over and over again, and let's just say it's a squat, if you perform squatting 3-4 times a week, yeah, you're going to get super strong at the squat, but to a certain extent, because you lack variability and one of the only movements that you're training is the squat too, that potentially can lead to problems as well if you don't instill variability in the program elsewhere. So all things to consider. It's important to keep your programs variable, but it's important not to become so variable that you impede the ability to get stronger and create an adaptation to occur. Furthermore, an often unconsidered factor of this is the impact that it has on you as a clinician. If you're always changing up the exercises, if you're always introducing new variables, then you have no way of knowing what helped. Whereas if you control variables and you manipulate or you change exercises on a more irregular basis, or you only change a couple certain exercises up every once in a while, you have a better understanding of what exercises are helpful and what exercises are not helpful or perhaps causing more harm. And because you're not switching up the exercises so often, now you actually have the ability to do the task repetitively, so you can actually get better. The only way to get better at doing something is to repeatedly do it. So if you keep repeating some of the same exercises over and over again, you can get better at that exercise quicker. Plus, you can have a better understanding of if that exercise is helping, harming, or really not doing you any type of good. So then you can become more efficient as far as what exercises are useful based upon the pain presentation that you're treating, so that when you go and treat that pain presentation again, you have knowledge or results to go back upon to know what was useful or what was not useful in the past. Whereas if you throw all the variables or all the exercises all at once, then you have no idea what exercise or what activity was helpful for that particular pain individual. So when you see that pain presentation again, you have to throw the whole kitchen sink at them again because you don't know what was helping, what was harming, or what really didn't do you any good. So controlling variables helps us as a clinician, and controlling variables and not manipulating exercises all the time allows the individual to get stronger and better coordinated or better performing the particular exercise itself because they've done the task repetitively. Now, the last point that I want to bring up is if you just kind of stay doing that same exercises all the time, then yes, you'll get very good at doing that exercise. Just like if you did the squat repetitively in the program, likely you're going to be pretty darn good at squatting. Or if you were to sit for a prolonged period of time, then likely your body's going to get very good at sitting. So your body's going to take adaptation to the shape that it takes on most. So your mom was right from that standpoint, is if you frown too much, the frown or that frown on your face is just going to get stuck that way. So you don't want to do it too often. But your body and movement is no different. As if we're only emphasizing the squatting pattern, likely they're going to get fairly well good at squatting, or likely if the individual is sitting all the time, likely they're going to get very good at sitting. But again, that's just one shape that the body can take on. We need the body to be able to achieve a variety of different shapes to have a more resilient and a more variable body, so that we can, again, redistribute pressure and not fall prey to that hardwood chair analogy that I keep referring back to. The final stereotype is the pain science folk. And this is number 12, and I'm saving it for last because it's a tricky line to walk here. It's also one of the more newer concepts that's been brought about in the rehabilitation, strength, and conditioning environments, is to get a little bit more educated on the whole science that is pain. And what we understand now is that pain is multifactorial. There's a lot of different contributing factors to why someone can be in a painful experience. But the ironic part about all this is that research is still continuing to try to find the one thing that caused or helped the problem. And so that's pretty ironic from a standpoint of, we need to do that from a research standpoint. In order for research to work, you have to control variables, but from a standpoint of what can be contributing to someone's pain, again, pain can be multifactorial. There's a variety of different percentages that someone's pain could be based upon. So, just think of it like a pie chart. Again, there could be 10% due to somebody's fear. There could be 10% due to somebody's actual tissue damage that has been done to the particular area. There could be 25% due to that because they're catastrophizing the problem, and they think the world's going to end because the issue is so traumatic or significant in their life. Furthermore, that's probably creating some sleep deprivation, which maybe that's another 10% of what's contributing to their pain. So again, there's a lot of contributing factors, and we don't necessarily know which factor is causative of their pain, if it is even one factor. So that's the irony of research, which is that we're never going to find one particular thing that is going to be a causative factor of every single individual's pain presentation, which is why it's extremely important for you to perform a research-based approach in how you treat every single individual, not from a standpoint of sticking to only what research says, but from a standpoint of how you introduce treatment variables into your plan of care. That is treating with evidence-based medicine, because then you can manipulate those variables accordingly depending on what the result of every single experiment with that person is. If you found a positive impact of those exercises, then you continue doing more exercises or similar activities. But if you threw the whole kitchen sink at them at once, 10 different exercises and manual therapy treatment, exercise, 6 different exercises, you don't necessarily know what's helping the individual. Whereas if you introduce 1 to 3 things, now you have a great deal more sense of what is useful, what is not useful, what to do more of, and what to do less of. So yes, it's important to be research informed, but you also need to be research based in how you practice by being able to control variables so you can elicit a better outcome. Now, when I say we're walking a tricky line here with the pain science, what I want to talk a little bit more and just touch on briefly is the whole standpoint of tissue damage does not necessarily correlate to MRI or the X-ray. And this is the whole phrase that you are not your MRI or X-ray that is kind of being brought about on social media and around our profession as well too. And I think it's a useful phrase to not internalize what our imaging is saying, because words can hurt you, so you need to be careful of what and how you say it, because you don't want to create fear and anxiety. But this is where I think we're skating on thin ice, is we need to be careful with this though, is if we take this to an extreme, your client is going to do one of 2 things. So this is where your ability to recognize the type of individual that's in front of you and how to communicate with them is extremely important, because if you don't acknowledge that their problems are real, because it still is their problems, this experience that they're having is very, very real, and you keep telling them that they're not their MRI, or the MRI is not really that important, there's people who are going to take offense to that, and there's people who are going to think you are not listening and you do not care about their problem. And that becomes problematic because you're not building trust in a relationship with the client, and they're not going to buy into your plan of care because you think that you're pushing an agenda on them and that you don't care about what all these other medical tests have been telling them. And that leads to the problem of you could have been doing the right thing by trying to educate them and trying to change somebody's false beliefs, but you have to understand there's a false belief there because that's been ingrained in their brain for such a long period of time that you're not going to change it in one interaction with that individual. You're going to have to space this out over multiple interactions and gradually kind of chip away at it. Misconceptions are not changed overnight. Beliefs are not changed overnight. Same thing with false beliefs. Even if they're false beliefs, they're still a belief and they're not going to be changed overnight. So you have to kind of chip away at it and gradually present your case to them, so hopefully that they can come to the conclusion that it was a false belief that they had. Whereas if you tell them it was a false belief and that what they're currently believing is not true, then they're going to resent that. They're going to become offended by that potentially, and they're going to resist change, which is the exact opposite of what you're trying to do by presenting this information to them. So you have to be careful of how you present this information, or you're going to actually do more harm than good for that person. Then furthermore, the other way that this could go is that the person kind of takes you kind of from the other standpoint, is that you don't actually create urgency about the problem. So that the person think, oh, well, the x-ray doesn't correlate to my issue, and I may not actually have a big problem, or it's just a strain, no big deal. I'm just going to try to see and wait, see how it goes. In 6 to 8 weeks, you said most soft tissue injuries resolve, so I'm not going to do anything. I'm just going to rest and not come back to treatment, and just kind of wait it out and see how it goes, because I don't think that this is significant anymore. And because I don't think it's significant, because you de-emphasize the impact of this injury, they don't think that they need your help now. So they're just going to wait and see if it gets better on their own. And we all know how that's going to go. That's going to go and lead to absolutely zero change, because they're going to keep doing the same things they have always been doing. So you have to be able to instill urgency into someone to get their issue addressed. And if you keep de-emphasizing the significance of the injury, or the significance of getting it addressed in a timely manner, then likely they're not going to feel the urgency to address the issue. So again, this is why I say we're skating on thin ice, because we know that the words we say are going to impact someone greatly. And if we say it in the wrong way to the wrong person, they can internalize that, and it creates a very big problem that could lead to false beliefs. But if we don't be careful, we're going to come off as we're not listening to the problem, or we're going to create friction upon our client to patient relationship that's going to impede our ability to progress or potentially change the false beliefs, or they potentially lose all urgency in addressing the issue because you de-emphasize the fact and the importance of it getting addressed in a timely manner. So there's a lot of gray area when we're talking about this. And rehab isn't as simple as find what doesn't hurt and do more of that. Yeah, we want self-empowerment, but we have to create urgency, confidence, authority, and awareness about the problem so that the individual will take action. Them taking action is the biggest first domino that needs to fall for them to start making progress. And if they don't have urgency, confidence, and authority and awareness about the problem, and you haven't talked about all of those things with that individual, then likely they're not going to proceed forward into getting treatment for their issue. And likely, if they don't proceed forward into treatment, nothing's going to change. And they're still going to be living with the problem that they currently have months later down the road, because you didn't emphasize these factors right here. People are indecisive in the first place, and if you give them an out, they're going to take it. So you cannot downplay the problem, because if you do, the client will likely go down the street to some quack selling snake oil who promises to fix their problem months later after you did not fully address their issue. And that doesn't do them any good either. So sell your damn self, and sell your expertise, and sell your service, and do not be afraid of doing that, because if you don't, then they're going to go to some quack again who's selling them snake oil, who's going to just create more and more false beliefs, and it's going to make it harder and harder for you to change that false belief in that individual. So you have to be understanding. You have to realize that any type of false belief they may have currently is going to take some time to change. So don't try to change it on day one. Day one, you need to create urgency, confidence, authority, and awareness about the problem so that the individual takes action and allows you to chip away at the problem and their false beliefs gradually over the course of a treatment plan of care. And that's going to give you a lot more chance for success, as opposed to trying to go into a big pain science talk or trying to fix your false beliefs all within one session, because inevitably, I've seen it in many clinicians, and I've done it myself when I started to dive into pain science. The pain science realm is that they think the opportunity to start educating somebody on all of this is in the initial examination or those first few treatment sessions, when realistically, that is the worst time to start introducing it. Yes, maybe you can kind of gradually or subtly introduce those concepts, but that person does not know, like, and trust you yet. And they do not. And as a result, your ability to actually change a false belief at that moment in time is very, very minimal. So you're better off spending more time focusing on creating urgency, confidence, authority, and awareness about the issue so that you sell your service, sell your expertise. They come back for a full treatment plan of care, and now you have a course of 10 to 12 treatment sessions to make a change in that false belief and in their pain problem, as opposed to trying to do it on day one when you're first meeting them. All right, so that just about wraps it up for this presentation. I hope you get a lot of information out of this, but what I want to just leave you with is that you're going to have to turn knowledge or this information into wisdom by using it into practice. If you just listen to this webinar and that's all you did, but you never go back and apply it to how you practice, then nothing's going to change. Again, this whole concept of learning by doing, you have to take action, which allows you to reflect on how that action went so you can conclude that did it go well, did it go poorly, was it indifferent, and then you can decide from that outcome what went well, what you could do better, and what you need to do differently, so that ultimately when you go back to doing it again, you change and you continually evolve and you continually change how you practice. But it's your awareness to not fall prey to these stereotypes that allows you to self-reflect better in your treatment and continue evolving as a clinician, as opposed to thinking there's only one way of doing something. And no matter the patient or client that walks through the door, I'm going to keep treating them the same, and I'm not going to adapt my thinking to the individual. So this is an ever-evolving process. This is an ever-evolving state. Where you are now is not where you're going to be 6 weeks from now. It's not where you're going to be 5 years from now. So you have to continually be able to, on an open mind, reflect and come to conclusions to ultimately change how you practice. Recognize that bias is going to live within everything, and depending on the situation, you're going to want to be on one side of the coin a little bit more so than the other. So if you understand both ends of the spectrum, you can live on the edge of that coin, which allows you to shift your bias to one side or the other of that coin depending on the situation. So it's not that you need to be on one side of the spectrum or the other side of the spectrum. It's your ability to live at the edge or in the center to bias yourself as much as necessary into either end of the spectrum, depending on the situation and the scenario. Which brings me to my final point, which is going to summarize this all again. It's not about the tools in the toolbox. Again, that to a certain extent is its own myth about the profession too. It's not what you currently don't know, it's what you currently think you know that just isn't so. That's what's potentially more harmful, or the question you need to ask yourself to develop more as a clinician. And instead of thinking, how many different tools can I add to the toolbox, think about how can I best utilize the tool given the scenario. It's not the paint that makes the painter. It's not the tools that make the carpenter. It's not the ingredients that make the chef. It's how they're able to utilize that paintbrush to perform art. Or this is my buddy here on the right. He is a chainsaw artist. He made this out of wood and a chainsaw. He didn't need any fancy tools. He had simply a chainsaw and was able to create art. All the chefs have the same ingredients, but yet the way the chef combines the ingredients in the right dosages and how they present the final product makes all the difference. So rarely is it a tool problem. More likely, it's how, when, and why you utilize the tools that you currently have at your disposal. And if you'd like more information about how to practice more freely, get more clarity on your treatment plan of care, when, why, and how to use a particular intervention based upon a particular pain presentation that walks through your jaw so that you can perform treatment interventions effortlessly and without stress, so you can enjoy your time in your clinic and then have the energy left over for when you go back home to enjoy your time with your family, then these are the 2 courses for you. It's a certified sports rehab expert program, it's our human assessment mastery, and our full body treatment domination courses. Everything you need to know rolled into just 2 courses. And then if you want continuing support, then we have the sports rehab expert membership area, which provides ongoing content released, as well as the ability to continually communicate with us throughout the year, ask questions, get feedback, and continue this whole process of learning by doing. So if that sounds like something of interest to you, be sure to check out these 2 programs, and I hope you got a lot out of today's presentation. Thank you for your time. Hope you all have a great one, and hopefully we'll catch you in on one of these programs in the near future.